Hello, this is Dr. Hemorrhagic, retina specialist in Hemorrhagic Eye Clinic in Aleppo, Syria. I am presenting the course of structural Enface OCT, and in this presentation, I will present the findings of structural Enface OCT in Bruch's membrane choroidal vascular diseases, part 2. In serous pigment epithelial detachment, the RPE slab will show a central homogeneous hyperreflective oval or circular due to pigment epithelial detachment PED content of clear fluid with hyperreflective borders which can be regular or irregular. The slab might show hyperreflective pockets in cases that serous PED is associated with subretinal fluids. The RPE slab will show the extent and size of the pigment epithelial detachment. In the inner plexiform internuclear layer slab might show the hyperreflective circle with a smaller diameter with more prominent hyperreflective borders depending on the serous PED's height and the segmentation. This slab might show cystic changes if the PED is combined with intraretinal cystic changes. The choroidal slab may show segmentation artifact in the form of a hyporeflective circle. In hemorrhagic pigment epithelial detachment, the RPE slab will show hyperreflective mass elevation with defined borders and might be associated with hyporeflective pockets due to subretinal fluids if presented. The inner plexiform internuclear layer slab might show smaller hyperreflective mass and thus depending on PED height and OCT segmentation. This slab might show cystic changes if the PED is combined with intraretinal cystic changes. The choroidal slab may show hyperreflectivity due to blood and depend on segmentation level. In the B-scan OCT cross-section, the hemorrhagic PED will show increased reflectivity under the RPE due to blood accumulation. However, in cases of a high level of subretinal fluids, it can cause segmentation artifact producing hyporeflective patches at the choroidal slab level. Polypoidal choroidal vasculopathy appears as hyperreflective circle with hyperreflective content. However, the polyp itself will appear hyperreflective material. The IPL-INL layer will appear depending on structural changes induced by the polyp itself. The slab may show tissue alternations due to elevation and counter changes if the PED is high enough. However, if the subretinal fluid is high enough, it will appear as an area of homogeneous hyporeflective area. Adjusting the slab will show the extent of the polypoidal choroidal vasculopathy from Bruch's membrane to the RPE layer and abnormal vascular network. Some cases can exhibit hyperreflective dots that are sites of polypenetration of Bruch's membrane. The RPE slab will show projection artifacts from the subretinal fluids, but shows the PED area as a hyporeflective circle with hyperreflective borders. In this case, the hyperreflective borders are masked due to shadowing. Please note motion and blink artifacts. The choroidal slab will show dilated vessels simulating dilated halars, which can be focal in cases of thin choroid or diffuse dilatation of halars in thick choroids. Enface OCT can be used as non-invasive method to screen the entire area of the choroid and polypoidal choroidal vasculopathy. The Enface OCT can help assess the treatment efficacy and structural changes post-treatment changes to the PED content, and other changes such as hard exudates and resolution of subretinal fluids, as shown in this slab post-treatment of the same case presented earlier. Please note the out-of-window artifact. In cases of central serous chorioretinopathy, the IPL-INL layer will show the neurosensory tissue elevations and contour changes. Some cases will show increased reflectivity in area of increased photoreceptor thickness. The adjusted segmentation slab on the subretinal fluid level will show homogeneous hyperreflective area depicting the location, size, and distribution of the subretinal fluid. The hyperreflective contents of the subretinal fluids can also be seen as hyperreflective dots in the slab, especially at subretinal fluid boundaries. The RPE slab usually shows projection artifact of the subretinal fluids. The RPE slab can be adjusted at the RPE changes level and can show RPE granular or alternation in the form of hyperreflective lesions. The choroidal slab will show dilated vessels simulating dilated halers, which can be focal or diffuse. However, some cases can show ischemic changes, which presented as hyperreflective cystic changes. In contrast, the presence of hyperreflective lesions may indicate the activity of the disease. In cases of central serous chorioretinopathy, pigment epithelial detachment will appear as an area of hyperreflective borders with hyporeflective content. A segmentation of subretinal fluids containing the PED or RPE alternation will show increased reflectivity corresponding to the area shows leakage in fluorescein fundus angiography. The IPL-INL layer shows hyporeflective cystic changes only in cases of central serous chorioretinopathy associated with intraretinal cystic changes. The structural Enface images can help to have a pan look at the distribution and size of subretinal fluids in central serous chorioretinopathy, and segmented slab may provide additional information about RPE changes. Thus, Enface can be useful to follow up and to assess the disease's natural course or post-treatment efficacy, as shown in this slab post-treatment with subthreshold laser of the same case presented earlier, presenting resolution of pigment epithelial detachment in the RPE slab, along with absorbed most of the subretinal fluids. Thank you for listening. Please visit my website www.amretina.com, where you can find more online courses and online guidelines.